Mobility and Immobility, Introduction to Nursing Concepts. This is Martha Olson. Safety is important no matter what age. We have to, as nurses, anticipate safety concerns for the very young and very old, and then everybody in between based on what is going on with them right now. As we look at the principles of mobility, we know regulation of movement is with skeletal and the nervous system working together. And with one problem in one of the systems can affect mobility. The joints, ligaments, tendons, and cartilage are part of that skeletal system. So we think of broken bones or sprained ankles causing mobility issues. Our nervous system is that balance, assisted through the control of the nervous system from the cerebellum and the inner ear. Inner ear infection causes that feeling of dizziness and loss of balance. We also think of things like Meniere's disease. Within that inner ear are the fluid-filled semicircular canals. In the hospital, when we get to clinical, we have to make safety a priority, and with that goes mobility. Which patient walks with one? Which of these patients would need a gait belt, a walker? Which patient would have orthostatic hypotension that we would have to be thinking, I need to get them up slowly, I need to allow for that blood pressure to readjust. As we look and assess patients, we have to constantly be thinking about what each person on the floor will need and how will we balance that heavy load. What will we delegate to that nursing assistant to help us with for mobility. Looking at normal motor function skills, we know that having good supportive shoes on is important. Slipper socks are good, but if you can get shoes on them, that's even better. Allowing them to dangle so that they can kind of get their blood pressure figured out and kind of get their bearings or figure out what's going on. And then give the support from the gait belt. As you see this nurse walking an elderly patient, she doesn't have a gait belt on. If this patient starts to fall, she probably will grab her under the arm and could cause brachial nerve damage from that. And so having a gait belt on is an anticipated part of ambulation for all patients. There are nurses I know that have been fired because they were walking a patient that had a new total knee replacement. The patient fell and had to have another knee put in at the cost to the facility. So when we look at regulation of movement, we know that it is the muscles helping us. The person's ability to move around independently within the environment needs to be assessed. We have to look at the effects of immobility and bed rest, and we'll be talking about those more. And when we think about resting for 1 to 2 minutes before a patient stands up, that's important to prevent that orthostatic blood pressure fall. The longer the period of immobility, the greater the physiological changes, especially to the circulatory system. Add on top of that things like blood pressure pills that are going to affect the circulatory system and the ability to regulate that blood pressure. Clients should never lean to one side because then their center of gravity is no longer midline, and that distorts their balance and increases their risk for a fall. As we look at other things that interfere with motor function, we know that unsteady clients fall if their center of gravity becomes unbalanced. In this picture, we look at this young child that has both of her legs casted. And in the picture to the right, your patient with Parkinson's that has the stooped over bent gait and also the shuffling of the gait. With those, they become very high risk due to motor function, and those would be, for the Parkinson's, it would be a neuromuscular condition. Again, we use a gait belt. Holding the arm is incorrect because if the client should fall, we can't support them, and so these patients definitely would need to have a gait belt with them or used on them. Our benefits of exercise and ambulation are to the heart. Increasing the cardiac output. When we walk and ambulate, it helps get that heart going, and it improves that heart muscle, making it stronger. Pulmonary, we've done that in the oxygenation unit. It improves alveolar functioning. It gets rid of the dead air to the bottom of the lungs and improves how they take a good deep breath. As we look at improved tolerance to stress, we know the benefits of regular exercise to our mental as well as physical health, and people that exercise report decreased mental problems and decreased illness. So we need to teach our patients the benefits of exercise. Choose something that they enjoy, do something on a regular basis. Start slow and work up until you are working your heart and working to your maximum. And you don't necessarily have to join a gym to be physically active, there's a lot of things you can do. I know here at the college we have a lot of older people in the community that come out here to walk. With mobility problems, we think of congenital defects such as muscular dystrophy, children or people with spina bifida or cerebral palsy. Things that affect postural abnormalities, the alignment and the range of motion. Impaired muscle development, that's your muscular dystrophy. Central nervous system damage like strokes or trauma. Many of our disorders that impair the skeletal system like osteoporosis and arthritis. Motor vehicle crashes, falls, fractures fall under that trauma. And if you ever work in a neuro unit or some of those, you will see a lot of these mobility issues after a traumatic event, a motorcycle crash, a fall from a tall building, or even a fall off of a ladder or something as people are working around their homes. As we look at hemiplegia after a stroke, stand on the client's affected side to support with the belt, and then help them along with their ambulation from there. And then we also look at foot drop, and I worked with a patient long term one time that was developing foot drop, and we went and got tennis shoes with the high top, and so we could put the shoes on him several times a day, lace them up past the ankles, and it helped prevent foot drop for him. As we look at interventions of impaired physical mobility, teach a client how to call for help, have him get out of bed or exit on the strong side, place the chair on the stronger side. We do active and passive range of motion for them. The passive range of motion is to the side that's totally flaccid, so they don't get contractures, and have them do that range of motion to the side that they still have the ability to move, or the unaffected side. When we look at using the walker, we know that they should not overextend as they're walking because that offsets that center of balance. We have to see how they tolerate it. Were they only able to get to the bathroom and they were winded and short of breath and they had to return back to bed? And then anytime somebody's up in the chair, we want to reposition them more often, because all of the weight is on that coccyx or center of gravity area where they're sitting, and there's a high risk for decubiti then to the buttocks for that person. The reposition every 1 to 2 hours in bed is a nursing judgment. Every 1 hour if they're very high risk. If that Braden scale for skin breakdown falls 9 or less, we would want to reposition them every hour if we can. And think about how would you incorporate range of motion into daily activities. During the bath, when you have the patient's joints relaxed and warm from the warm bath, maybe do some range of motion while they're in the whirlpool tub. As we look at our body mechanics, this is as much for the patient as it is for you, the nurse. Make sure that you are using proper body mechanics to not hurt your back. You only have one back, and you want to make sure that you are not having an injury so that it puts you out of being able to do patient care. We want to keep our stomach muscles strong, doing your ab crunches and all of that. Keep the core strong so when you do your lifting, you aren't straining on those back muscles. Bend at the knees. Your thighs are the strongest muscles in your body, and when you bend at the knees, you're using the weight or the muscle in the thigh to help you. Do not twist. Don't turn so that you're lifting and causing extra strain on those lower back muscles. And then we lift to the center of gravity. Your internal girdle is the muscles where you want to pull the buttocks down to reduce the back strain. Use your long midriff, meaning hold the chest up and keep your back straight. As we look at other body mechanics, if you need something that's up high, get a step stool. Don't get on your tiptoes and don't get off balance, because when you're reaching up high, it takes your center of gravity off you. When you want a strong center of gravity, hold your feet apart so they're even with your shoulders, because that gives you the best chance of being able to balance without tipping over. And that's that maintain that base of support. As we look at tightening the stomach muscles and tuck in your pelvis, bend at the knee, keep weight close to you. Don't carry things outstretched so that you're putting the stress on that lower back. And again, avoid twisting if at all possible to avoid those back injuries. So as we look at a question that might pertain to this, you're working with a client who is only minimally able to assist the nurse in moving from the bed to the chair. The correct technique for lifting the client to stand and pivot to the chair is number 2, maintain that wide base of support with your feet apart as wide as your own shoulders. As we look at immobility, there are a lot of psychosocial effects that go along with that. If I can't move, I'm going to feel that decreased social interaction and stimuli. And clients use a call bell a lot to request minor things that they want attention for because their real need is greater socialization. Many of them will become depressed and not eat. Many of them will become very quiet and socially withdrawn and not really want visitors, and so we have to kind of always be assessing for immobility some of the other effects besides just physical. Developmental effects of immobility, we know that the longer it goes on, the worse it's going to get. Their muscles weaken, their bones get weaker, they lose their appetite, their GI motility, the peristalsis slows down, the basal metabolic rate slows down, circulation, their blood gets sluggish down in those lower extremities, and that just leads them into things like blood clots and other complications. And so getting patients out of that immobility into mobile is very important, and that can be very difficult on some of our patients that have some very severe injuries, or maybe they're on a ventilator for an extended period of time. Prolonged immobilization delays in children their gross motor skills. You know, a child that has problems and they spend a long time in the hospital or a long time casted will not be able to run and kick a ball and crawl and do all the things that children their age are doing because they're losing that time of developing those motor skills. And some of that goes back to your growth and development class. With our older adults, they lose their independence. And for them, not being able to drive, to be able to walk, to do all of those things, they can become very depressed. No body system is immune to the hazardous effects of immobility. The greater the extent and the longer the duration of the immobility, the more pronounced the consequences will be noted. Each body system is at risk for impairments resulting from immobility. As we look at some of the changes in specific body systems, we know that many elderly are able to swim, and it's very easy on the joints because it doesn't put a lot of stress like running and some of those other things. So many of your older people will get in warm water because it eases arthritic pain. There's a picture of Brett Favre because most of your NFL players don't play beyond the age of 31. He was kind of the exception. After 31, the physical demands of the body by football make it kind of impossible to play. And as you look in your book, there is an assessment of physiological hazards of immobility I would highly recommend you look at. Some of the specific systems then are respiratory. These are things that happen, and we have covered these in the oxygenation unit. Our priority is airway, so we don't want that patient getting that term called hypostatic pneumonia. Inflammation of the lung from stasis or pooling of secretions. They lay in bed, they don't take good deep breaths, and they get this condition called hypostatic pneumonia, which can be prevented with incentive spirometry, getting them up, coughing and deep breathing, and possibly breathing treatments if they need. Orthopnea is where they have to lean on the bedside table to breathe. Atelectasis is that collapse of the alveoli. Secretions stagnate and pool in the dependent regions of the lungs, so even repositioning them within the bed during the night is important to prevent them from getting secretions that are just in one lobe. As we look at the intensive care unit, any patient that's intubated and on a ventilator would be very high risk. They can become septic and hypotensive as a result of the immobility and bed rest, and many of them can have to be sedated in order to keep the endotracheal tube in place when they are in the intensive care unit on a ventilator. A condition called deconditioned is where they just become so weak and so tired they're not able to do things for themselves. A dietitian referral for when they're off the ventilator and able to eat, and if not, we will be very soon talking about total parenteral nutrition as a way to help with the person that is not able to eat. This ends number 1 for mobility.